All right, greetings to tonight's webinars from Optometric Education Consultants. It's oral antibiotics and antivirals in eye care, and our presenter will be Dr. Greg Caldwell. Dr. Caldwell is a graduate of the Pennsylvania College of Optometry, where he also did a residency in primary care and eye disease at the college's Eye Institute. He has been involved in numerous FDA clinical trials throughout his career. He is currently a consultant in ocular disease and disease management in two practices in Pennsylvania and Youngstown and Johnstown. And he has been a friend of optometry for many years. He is past president of the APOA. He serves on the Foundation of Blindness, as well as being the past trustee for 3 years of the American Optometric Association. Dr. Caldwell has done extensive work lecturing and enhancing eye care throughout the world in most states and several nations, and has done a lot to advance the care of patients in the profession of optometry through organized optometry at the state and local level and national level. So with that, a nice warm virtual welcome to Dr. Greg Caldwell.
Thanks, Joe. And I'll jump in here to my disclosures. Just one little clarification. I was down in Florida, and I believe Joe said FOA, Florida Optometric Association. Maybe someday I will be.
Oh, I'm sorry, the Pennsylvania Optometric Association.
POA. So, yep, that's yes. Okay. No biggie. Just to clarify for those that are out there. So my disclosures, the content of this webinar was prepared independently by me. You can see the whole list of who I've lectured for, from Alcon to OptiView, advisory boards, Allergan to Dompe. I serve as the PA medical director for Involve, which is a managed Medicaid. I'm involved with a registry as the chairman of advisory council. I have no financial proprietary interests in any of the companies that get mentioned today. And probably the strongest statement on here is that the content and the format of this course is presented without commercial bias and doesn't claim any superiority over any commercial product or service. I am half owner with Dr. Saka of Optometric Education Consultants. Thank everyone for being here. So to jump into the presentation, we're going to talk about the FDA pregnancy categories. We'll talk about antibiotics as anti-infectives and anti-inflammatories. We'll talk about antivirals. And the biggest thing that I like to do when I lecture is just to kind of show people how to apply them in patient care, avoid pitfalls, and increase confidence when selecting an oral antibiotic or antiviral. So I'm just going to animate this whole slide. This was the original FDA category. I kind of liked it because it was really easy: A, B, C, D, or X. X just sounds bad, so it would most likely create fetal abnormalities. The whole idea is they really don't do drug testing on someone that's pregnant. How they usually get a lot of this information is someone doesn't realize they're pregnant, they're taking a medication, and then they're able to find out whether or not there's an adverse effect. So that's why you'll see in category A, studies in pregnant women, no risk. Those are mainly women that didn't realize that they were pregnant, and then they were able to have enough data to make a conclusion. Category B is animal studies, no risk, but humans not adequate, because again, they don't test. And you can see here, basically A and B are safe. You want to start scratching your head a little bit in category C. And then when it comes to ocular infections, if they are D or X, you'll want to avoid. But that has changed. There was a rule in December 4th, 2014. They called it the Pregnancy and Lactation Labeling Rule. It went in effect on June 30th. And it basically focuses on pregnancy, lactation, and then the reproductive potential for females and males. So when you look at a package insert, if you just want to jump just to that information, you just go to section 8. 8.1 will talk about pregnancy. 8.2 will talk on lactation. And 8.3 will be talking on the male and female reproduction. So I just kind of wanted to show you, we'll be talking about Valtrex a little bit later, and you'll see here that Valtrex was a medication that was before the rule. So they still had to adapt. You could see that when you look at this page here, it says 8.1 pregnancy. There's nothing on 8.3 or 8.2, but there is something on 8.3 on nursing mothers. But if you do come over and look at 8.1 under pregnancy, they still listed as category B. So they still use the old nomenclature from previous, but they've also adapted to the new printout for 8.1, 8.2, and 8.3. So you can see 8.2 is missing because they don't have any data. So 8.3 here is on for the nursing mothers. So if you go to something that was after this rule came out, and just I added this a while ago, you could see it's Xiidra. And if you jump over, you can see that there's really no A, B, C, or D listed here, and it goes through the pregnancy risk summary and data. There is something on lactation under 8.2, but you can see that there's nothing under 8.3. And then this one just came out. This came to the office the other day, and I opened it up and I said, oh, well, I'll put it in here just for the fun to keep things updated. This is UPNIC. And you can see if you jump over here, you could see that they have something under 8.1, but again, no A, B, C, or D. And then 8.2 is lactation and nothing under the reproductive system. So that's the kind of the change and where you look for it. So Joe, can we launch polling question number 1?
Yes, we can.
Patient has a severe allergic reaction, penicillin Encapflex. It's like EpiPen-like. It's that severe. Which antibiotic would you use for this dacryocystitis? Would it be Augmentin, Azithromycin, Keflex, Bactrim, or Cipro? So they have a severe allergic reaction, EpiPen-like, anaphylactic-like. You have a dacryocystitis here. I'm pushing on the nasolacrimal sac. You can see the pus coming out. And which antibiotic would you use to treat this infection?
All right, we're doing pretty well. We're past 80%, Greg.
Okay. And
Still
when
coming
you feel comfortable, go ahead and end the poll and share the results.
I will. And I think for sake of time, we're going to do that. We're going to end the poll. I'm going to show the results.
And we'll see here as we go through. I'm going to repeat this question here shortly after we go through the antibiotic review here. And Augmentin is a penicillin derivative, so we want to probably avoid that. And Keflex, there's about a 10% cross reaction. The majority at 37% went azithromycin. That's a great choice. And I would agree with the polling audience, but those who said Bactrim is another good solution. There's just things you have to remember. And Cipro is another. And I don't know is a good answer. And that's why we're here tonight. So we'll see how that changes as we go through the webinar here. So here's my antibiotic paradigm through 2019, and I'll show you what happened in 2021. So under penicillin, you have Augmentin. Under the macrolides, you have Zithromax. Cephalosporin is Keflex. The quinolone group is Cipro, and Sulfa is Bactrim. That was my paradigm through 2019. What happened is the first 3 stayed the same, and I'll go back. You'll see that Cipro is now went from the 4th position to the 5th position in 2020, and then 2021 it still stays the same. And there's a lot of things that are happening with Cipro, and that's what you'll see is why it moved down to the 5th position. And the only one that's really not on here that we could add at some point would be clindamycin. If someone has an allergic reaction to all of these, that would be my go-to antibiotic. So when it comes to cross reactions, the only one you really have to be aware of is penicillin and cephalosporin, but really just the first generation. I'll explain that here in a slide coming up. And then just have to be careful with the sulfa-based medications. If they're allergic to the antibiotic, there's a good chance that they're going to be allergic to the other sulfa medications, but it doesn't really go in reverse. And Dr. Alfadal does a really good job. It's a pharmacist that I lecture on. But the key here is just be careful here be careful if they're sulfa medications, just avoid it, find out what the reaction is. And there's plenty of other antibiotics to choose from when it comes to that category. So I have a lot of colleagues that will say, man, I never really use amoxicillin because I get treatment failures. And the reason being is that you just didn't couple it with clavulanic acid. I did this talk with Dr. Offerdahl. She's a pharmacist. She teaches at Salus University. And we probably started lecturing about 7 years ago together. When I told her this was one of my go-tos, she kind of like looked at me and she was like, man, why is optometry, Greg, why are you using such a big gun? Because augmentin, it's amoxicillin augmented with potassium clavuronate. And the reason why I go for it is because of what my colleagues have told me. They have issues with amoxicillin because, as you saw in that dacryocystitis, that it's a big pus producing type of infection. And that's usually what we see around the eye is the flora and the infections that we get are usually pus producing. So it produces beta lactamase. And if you remember, beta lactamase breaks down that lactam ring, and that's what makes those penicillins inactive. The key is when beta lactamase enters the room and it looks at amoxicillin and looks at the clavulanic acid, it's more attracted to the clavulanic acid. So it binds to that. Now the beta lactamase has been neutralized, allowing the amoxicillin to work. So if you had treatment failures with just kind of penicillin alone derivatives, that's the reason why. Go with augmentin. And I love my penicillin derivative because you're going to see the next two medications. There's not anything I really need to worry about as long as they're not allergic to it. So augmentin is really good for anywhere from 12 weeks old to geriatric patients. So I don't have to really worry about, are they 18 years old like we do with Cipro? It's safe in pregnancy. It's category B. All you have to do is watch for penicillin allergies. And typically, if someone is of kind of normal weight, normal size, it's 500 milligrams twice a day for a week to 10 days. When we're treating around the eyelid, what I found out, whether it's a sty or in this case where I showed you that dacryocystitis, it's very hard to get medication to the eye. It has to go through the blood-brain barrier twice. Even though the mouth is here and the eye is here, when you swallow the pill, it still has to go through the blood-brain barrier twice. So what I like to do is at times give the patient a 10-day supply and say, look, finish your antibiotic for 7 days. But if you think you need an extra day or two, I'm going to give you 10 days out there. And these medications are not that expensive, and it saves them from having to come back or call in your office. So I usually do augmentin 500 milligrams if it's a really, really big infection in a sense for 10 days. And you can see there, children less than 100 pounds, the oral suspension. Just work with the pharmacist, work with the pediatrician. And it's the 25 to 45 milligrams per kilogram divided into 2 dosages. So this is another reason why it's good, because it's good for gram positive and gram negative, right? We don't have to remember. So again, I like augmentin, gram positive, gram negative, children, geriatrics, everyone in between, safe in pregnancy. The only thing I need to remember is the patient allergic to penicillin? And if so, we avoid it. If that's the case, then we go to a macrolide, because macrolides are the drug of choice for penicillin sensitive patients. And in this case, I would use something like azithromycin, and a lot of us know it as Zithromax or the Z-Pack. And again, it's good for pregnancy, category B, no renal adjustment. And the key here is you just have to remember there's a 5-day Z-Pack, which is still 6 pills, along with a 3-day tri-pack, which is still 6 pills. So if you do a 5-day Z-Pack, it's 2 pills on the first day. And then for the next 4 days, 1 pill, 1 pill, 1 pill for a total of 6. If you do a tri-pack, it's 2 pills a day for 3 days. Remember that this medication will last into the system up to about 10 days. So be careful if someone's having a treatment failure, let them go through the full course because the medication does, in a sense, have some memory. You can see here it's good for gram-positive, gram-negative, and it's better tolerated than erythromycin. That's why azithromycin has come out. So when it comes to treating eye infections, really, it's a flip of a coin that comes to me. Is it going to be penicillin this day? Is it going to be azithromycin? If they have maybe a hint or a sniff of penicillin allergy, you can ask them what happened. If you still want to go with augmentin, go for it. If you want to default to azithromycin, because again, it's good for children. It's good for geriatric, gram-positive, gram-negative. The only thing I need to remember really with these two medications is the patient allergic to either one of the medications? And if so, just avoid it. It's good for chlamydia. It's the drug of choice. When you take boards questions, you just take 4 pills. You take 4 at the same time, a glass of water, and that's the drug of choice for treatment. So I always joke, Vision Expo West and going out to the McCarran Airport. I think that's the airport there. If you go to Vegas and you want to, whatever happens in Vegas, stay in Vegas. Make sure you grab, 4 pills of your azithromycin, grab a bottle of water on the way to the hotel, and take 1 gram of azithromycin. Just kind of a cute way to try to remember that. All right. Now, jumping into the cephalosporins. Now, there's like 7 generations of cephalosporins that are now available. We're basically just going to talk about 2 generations today. And in the first generation, where you are going to the 7th generation, you look less like penicillin at the 7th generation than you do at the 1st generation. So that's why if someone has a really severe allergic reaction to penicillin, just avoid Keflex, because I'm going to show you in a picture, I think it's the next slide, that the molecules look very similar. So there's a 3 to 10, depending on what you read, a 3 to 10% cross reaction with Keflex only because it's a 1st generation. And you have to start remembering things here. This is why we give Keflex to adults, is because adults usually get gram positive. Children, on general, gram negative. Geriatrics, gram negative. Kind of a rule of thumb. You can't always say always and never, but on the ends, beginning and ends of life, gram negative, in the middle, gram positive. So that's why you'll see, a patient comes in, we give them Keflex, right? We give them Keflex 500 milligrams twice a day for a week, for those lid infections. And if you're going to treat an adult or a child, it's going to usually go to a generation 2 because it goes for more gram negative. But sticking with Keflex here, you can see it's category B, 500 milligrams twice a day for a week. And you'll see that it's the drug of choice for blowout fractures. And that's why if you ever have someone come in over the weekend after they've been to the emergency room, car accident, a fight, they come in and they're typically on Keflex because the emergency room doc looks up, sees that it's a drug of choice. As long as they're not allergic to penicillin or Keflex or cephalosporins, they place them on that medication. Ceftin is a good medication. Usually I use it if it's a pediatric patient. The reason being it's better for Haemophilus and Haemophilus influenza, which is a gram negative. And that's typically what, again, we see children getting, and you could see the dosage here, children 3 months to 12 years old, oral suspension, 15 milligrams per kilogram divided into the 2 dosages. It's also available in 125, 250, and 500. If you're going to give it to an adult, and I'll explain to you an adult child here, and I'll clarify that for you. You're going to do 250 twice a day for 10 days. You'll hear me reference Tracy a lot. Tracy and I do a lot of lecturing together. She again is a doctor of pharmacology. So she's my phone a friend when it comes to those. Joe is my phone a friend when it comes to neuro. And a while back, I called Dr. Offerdahl and I said, hey, Trace, I got this, 12-year-old boy here. He looks like he already could play for Penn State here in 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 Pennsylvania. He's bigger than I am, more muscular. Obviously, he went through puberty. She goes, you just said it, Greg. Puberty. Boom. You could go with the adult dose. So that's kind of a little bit of a rule of thumb. So it says here, 12 years old, divided all up. If you called the pediatrician and they go, hey, look, Johnny is, 225, looking like a linebacker already, you can go for the adult dose on those. So just, it's more or less puberty is the key. And you can see here that Ceftin is category B. So here are some 3 structures. And the top one is penicillin, and I'm going to label these for you. The middle one is Keflex, and the bottom one is Ceftin. So I want to point out, as you can see right in the middle here, you've got, this, I always, tease in organic chemistry, we got this square and you got this square here, this pentagon and this hexagon. So if you have antibodies, if you have an allergic reaction to penicillin, this is what the body does. It recognizes this molecule and it says, hey, this is foreign. I'm going to have an allergic reaction to it. So what the body does is it comes down here and it looks very similar. And that's why there's a 10, up to a 10%, 3 to 10% cross reaction. It's down here, as you can see, that this molecule is starting to look a lot different than this molecule. And that's why when you start getting down to the 2nd and 3rd and whatever 6th and 7th generation cephalosporin, you're not going to have that cross reaction because it doesn't look like penicillin anymore. Jumping into the sulfa medications, I used to say limited use. The reason why I do that, it's not really the last line of defense. It's becoming one of the last lines. I put Cipro there. We still have clindamycin, but there's just reminds me that there's things that you have to remember when it comes to using sulfa, and that will be on the next page. So there's Bactrim single strength. You can see that it's 400 milligrams and 80 milligrams of the products that you see listed there. And then there's Bactrim double strength, DS, and then 400 goes to 800 and 80 goes to 60. Obviously, both are doubled there. That's the one I typically use when treating an eye infection is the Bactrim DS. Again, unless the patient is, 90 years old, maybe with some frail, liver or kidneys, very underweight, so on and so forth. Typical adult comes into the office, sty, allergic to penicillin, allergic to Keflex, questionable about, azithromycin or the macrolides. Okay, we're keep moving down the line. Okay, Bactrim double strength is the way I would go. 1 tablet by mouth twice a day. So, there's a lot of adverse drug reactions that can happen with the sulfa. You have sickle cell. You have to be careful in pregnancy. You have to start remembering things. Like in this case here, the patient this is category C. So the other 2 were A and B. If the patient was pregnant, okay. C, I would probably avoid. We know about the Steven Johnsons and the toxic epidermal necrolysis that can occur. And there are some cross reactions with some of the sulfa medications. So you just want to be careful when it comes to the sulfa medications in that case. Now we move into the Cipro and Levaquin. Remember, this used to be the 4th position. Now it's moved down to position number 5. And now it's the end of the line antibiotic. If the patient is allergic to penicillin, cephalosporin, macrolides, sulfas, it's not that they're not that they're not effective. These medications are extremely effective and they have a broad indication, gram positive, gram negative. But you want to only give them to children that are 18 years or older. And I want to clarify that because this is a fluoroquinolone. So does that mean you can't give a topical fluoroquinolone to a child? Absolutely you can. But you want to avoid, so that's the clarification. Topicals are okay. Orals are different for a couple reasons. Younger than 18, you can have oral issues, teeth that are stained, issues with the teeth, breastfeeding and pregnancy you have to be careful with. But then also, if you remember, if you stay up late and watch TV and, hey, have you taken Levaquin and did you have a tendon rupture? We may have money for you. And the key to that is they could have a tendon rupture that week. It's probably not going to happen, but it could be years later that they can get the tendon rupture. So you start getting into some adverse drug reactions when it comes to the fluoroquinolones. So there's been some reports out there about retinal detachment can increase up to 1 in 2,500. Now we heard a lot about QT prolongation with some of the newer agents and with, hydroxychloroquine and even azithromycin out there. So that's part of the heart rhythm and it's prolonged, and you could take this medication and prolong it even longer, and you can then create, a heart issue or even death. Tendon ruptures, it could be Achilles, it could be wrist, it could be anywhere. And remember, what is the vitreous made out of? If I said, what is a tendon made out of? A lot of people would go, oh, it's collagen and elastin. What is the vitreous made out of? The vitreous is made out of collagen and elastin. So this kind of goes back and forth. It's debated. I think that there's probably some association. There's probably something genetically that can be identified where someone has a certain genetic mutation to a certain collagen and elastin, and that's why that person gets the tendon rupture, or that person may have that type of collagen and elastin in their vitreous, and it could lead to a retinal detachment. I can tell you that there's probably some association, and this could be technique-wise, along with using the fluoroquinolone. But what I wanted to show you here, back in the day about 4 years ago, when our area was moving into dropless cataract surgery, here's a patient here. You can see not a real high myope, nothing staphyloma, no tilted disc, no straight, just normal looking posterior pole and periphery. But you can see this patient went through dropless cataract surgery. And again, I think this is technique and drug related, but check out the multiple. There's a big tear right here. You can see this big tear. There's another tear here. And then down here, there's another tear. You can see this patient really wasn't at high risk by looking at their periphery. And we did go through a little rash of, never hadn't seen a horseshoe tear in a while with cataract surgery. And I put on the red free on this one here so you could see how large these tears were. I find little holes and tears in retinas, probably about once a quarter, maybe a little sooner than that. We have to get them little horseshoe tears off to the retinologist. They're usually not this big, right? They're usually little when they're from PVDs. But again, this was cataract surgery, probably technique-wise, and then probably coupled with the fluoroquinolone. And that has since changed since out there. So with that being said, we just kind of did a real quick crash course on antibiotics. So here's this patient now, and just want to see if things have changed. It's the same polling question. So Joe, if you can do polling question number 2, here's that dacryocystitis. And that patient is allergic to penicillin and Keflex. Which antibiotic would you most likely choose? It's the same question as before. Just doing a little, see if things might have changed. Which one would you use in this patient? Would you do Augmentin since they're severely allergic to it, and Keflex? Would you do azithromycin? Would you do Bactrim, or would you do Cipro? Anything roll in here regarding questions, Joe? Are we okay?
I'm looking at the chat right now. Question is, what is QT?
QT elongation. Again, long when you have an EKG, there's all the different spikes, and there's one that is QT going from one point to the other. So it's just part of your heart rhythm, and it can be prolonged, and you don't know it. That's sometimes when you see the basketball players, they don't know they have it, and they're running down the court and they're healthy as can be, and they fall over and pass away. Or you could take a medication and someone already has everyone has a QT, it can prolong it, and it just doesn't allow your heart to beat. So it's just part of your heart rhythm, the EKG.
There are results. The vast majority said azithromycin.
Yep. Yeah. So there's 4 people that responded Augmentin. I would probably, if it's EpiPen-like, I would probably skip a penicillin to a penicillin. One person replied to cephalexin. Keflex is cephalexin. I would probably avoid those 2 if they're EpiPen-like. But Bactrim, again, if you feel comfortable going with that after checking with all the complications that can occur. And Cipro definitely is a great antibiotic that's out there. And obviously azithromycin in a sense, if you want to say, is your safest. And that's where 80% is. So good. And there was a little shift from now to, and I think a few people put, I don't know. And those people now answered. So great. That's what we do education for. So, here's the patient. Remember to check for allergic, remember to check for allergies, and they're allergic to penicillin and Keflex. So I did do a topical like Polytrim because they do have a little bit of bacterial infection, 5-day Z-Pack. Now, what I want to do is go with polling question number 3 here. And I kind of maybe want to undo some of the teachings that we did way back. So is a dilation and irrigation contraindicated or indicated? And I'll get poll 3 here launched. So dilation and irrigation. Is it contraindicated, indicated? In a sense, is it both? Or you just don't know? So you have this patient that comes in with this goopy dacryocystitis. Contraindicated, indicated, or in a sense could be both, or you're not sure. And as the poll was rolling in, I'm going to kind of tell you why I wanted to see this as a polling question. Back in the day, whenever optometry was getting the therapeutics and some of the states had to take that 100-hour therapeutic course, I was part of the 20-hour lab part. I felt comfortable teaching people how to do gonioscopy, putting in punctal plugs. We were showing docs how to do dilation and irrigation. And when we were doing dilation and irrigation, we would say, what's one of the indications and contraindications to doing dilation and irrigation? Contraindication was always a dacryocystitis. So I remember a doc calling me up one time after he sent me a dacryocystitis. An optometrist referred a case to me. And I wrote back in the letter that we put him on the Augmentin, treated him, cleared him up, blah, 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 blah. And then in the letter, I said, I did dilation and irrigation and found that the system was patent. And he called me up and said, why did you do a dacryocystitis? I thought it was, or a DNI on a dacryocystitis because I thought it was contraindicated. And I remember it just clicked. That's what we used to say. And the answer is yes, it's contraindicated, as most people have indicated in this poll, when it's an active infection. However, these patients usually come in sometimes saying it's their second or third dacryocystitis. And it could be because they have a blocked nasolacrimal duct or even the first one. So anyone that ever comes in and it's their first one, what I'd like to do once everything is resolved, could be 3, 4, maybe even 5 weeks later when things are all settled down, inflammation's gone, is I just like to just make sure that there's nothing in there blocking or there's some type of blockage in there. So for those who answered, say, 15% that said contraindicated and indicated, that's kind of where I was going with it, is that you want to see if there's a confirmed nasolacrimal blockage, not when they're in the active infection, when they're all cleared up. And if they are blocked, then you can send them for a DCR, which is a dacryocysterhinostomy. And there's 2 ways of doing that, endoscopically and externally. So, which group of antibiotics are we missing here for this webinar? And the group that we're missing are doxycycline and minocycline. So I just want to kind of talk about doxycycline and minocycline. And we're going to do that through a polling question. And the polling question is, when we use doxycycline or minocycline for dry eye disease, ocular surface, meibomian gland dysfunction, prior to cataract surgery, cleaning up that ocular surface, what property of the pharmaceutical are we benefiting from? Doxycycline is an anti-infective. It's anti-infective through bacteriostatic action. It has an anti-protozoa action, like for malaria. Is it because there's a lot of Staph aureus on the eyelids and it works well for MRSA, especially community-acquired MRSA? Are we trying to use it for the Staphylococcus aureus side? Or is it because it's an anti-inflammatory and we're inhibiting it through the bacterial lipases? Or you just don't know? And we can end that poll because it looks like the majority of the people are kind of nailing it along the way. And I think a lot of optometrists, and we've been beaten to death over the years with this, is that it's inhibiting the bacterial lipases is what it's doing. And it does have all those mechanisms of actions, but it's really, we're leaning towards inhibiting those bacterial lipases. So from this point forward, even though it does have protozoa action, it does have an antibiotic action, it does have a MRSA action, just like when you give aspirin at different levels, you get different effects. So when you give aspirin at 81 milligrams, you're really not going to get anything that's anti-inflammatory, anything that's antipyretic, because you're giving it at too low a dose. You're getting the antiplatelet. And as you give aspirin at different levels, you start getting different effects. And just what we talked about, antipyretic, you get anti-inflammatory out of those medications as you start giving higher doses. If you give minocycline and doxycycline at 100 milligrams twice a day, you're definitely going to get the anti-infective side of that, whether it's the protozoa side, whether it's the bacteria side. But if you give it at a low dose, and let's just say 50 milligrams once a day, you're going to get more of an anti-inflammatory side of it. So when we and dermatologists use it, we usually like to give it at a low dose, but more chronic. And think of that as a steroid. When people get steroids for chronic inflammation, they're just not put on it for a week or 7 days like an antibiotic and taken off. They're usually on it, started at a high dose maybe, and brought down. So think of your doxy and minocycline as a steroid. And here's a case, and you might have seen this if you've attended this lecture in the past or seen me talk about minocycline. This is a 48-year-old man, dry eye, red, gritty, sandy, dry feeling. You can see everything looks pretty normal here. You can see when looking at him, he has obvious rosacea. You can see the skin of his nose is starting to hypertrophy. We call that Rhinophyma. And what that tells us is that it's chronic. So we see telangiectasia of his cheeks, his forehead, his nose. Rhinophyma tells us that it's chronic. So we take a closer look and we see that this patient has this foam, this kind of frothy appearance sitting down here on his lower lid. And we see the inspissated meibomian gland. And then at times we can get these marginal ulcers. So his diagnosis is inflammatory blepharitis, meibomian gland dysfunction, evaporative disease, inflammatory blepharitis, meibomian gland dysfunction exacerbated by rosacea. Treatment, it's warm compresses, lid hygiene, and we have all these other things that are popping up out there with IPL and tear science with heating up the meibomian gland and expressing, but still some of the fundamentals of using fatty acids such as a quality EPA and DHA, maybe a dermatological consult. And to this day, even though when I do some of these fancy treatments, I still like to use minocycline or doxycycline, which in a sense, we know it as an antibiotic, but we're using it as an anti-inflammatory. And I'm going to walk you through this quick cascade of why and how. And this might help with some of your treatment regimens as you're moving forward. So Staph aureus and Staph epidermidis, normal flora on the eyelid, produce lipase. And anytime you see ASE, that's a reminder that that's an enzyme. So lipase breaks down what? Lipase breaks down lipid. What comes out of the meibomian gland? What comes out of the meibomian gland is phospholipids, right? It's an oil. It's a meibomian gland secretion of lipid. So if you think about the lipid beginning to break down, that's why the olive oil, like when you express, starts to become a little bit cloudy, a little bit turbid. And then if it starts to become more solid, that's when we start saying it's more inspissated. So it's just that lipase breaking down that lipid. So this marginal foam, if I would tell you I took some fat and some lye and some water, what would happen in that chemical reaction? Took some fat, lye, and water, mixed it all together, kind of a cheap form of soap, right? We would get a bubbling action. So think about the eye. We have an oil called lipid, meibomian gland oils. That would be your fat. We know that there's plenty of aqueous on the eye. What could be the lye part? The lye part is lipase. So you have lye, you have fat, you have water, and this is actually soap that's being produced on the eye. It's been studied, it's been proven, it's a soponification. That's why most of these patients that have meibomian gland dysfunction, when do they have more symptoms? Is it more in the morning when they wake up, or is it more in the afternoon? And what I have found in clinic, it's more in the morning when they wake up. They'll wake up and they'll say, man, doc, for the first like half hour, man, until I get blinking, until I start putting tears in there, my eyes burn. Well, if you think about it, it's because they go to sleep at night, they're not blinking, the eye is building up soap, the pH of their eye is shifting so that when they wake up in the morning, they have a pH shift because their eye has been slowly producing soap. And that's why they have those symptoms. So I like asking a patient that comes in with ocular surface disease, when do they have more symptoms? If it's in the morning, that really starts guiding me to start doing things towards treating the meibomian gland, cleaning up the lids, trying to get the pH issue solved at that point, because they usually have both, right? When you talk to the dry eye gods and goddesses out there, it's just not that simple, Greg. But it helps, and I agree, it helps me though on the focus. If they have more symptoms at the end of the day, it's usually more of an aqueous deficient slowly drying out, and the patient is, needs that type of focus as opposed to maybe that morning type of burn. Now, if you remember, a lipid is made up of what? A lipid is made up of a bunch of phospholipids. So if it took a lipid and carved it all up, it's a phospholipid. And you guys, when we all went to school, got beat into our head the arachidonic cycle, and then we have lipoxygenase and other enzymes that break down the arachidonic acid, and we get prostaglandins, thromboxanes, and leukotrienes. And if you remember, those are all mediators of inflammation. So the inflammation creates redness to the eyelids, swelling to the eyelid. You can see the conjunctiva is red and irritated. And what I want to focus on a little bit is this picture down here, where we have the white blood cells building up into the cornea, that marginal ulcer. When you have someone that comes in, and maybe I should make this a polling question, but to speed things along, if I had someone to come in, the polling question would be, if you have someone that comes in and gets a marginal ulcer from meibomian gland dysfunction, where would the ulcer most likely be seen in your office? Is it at 12 o'clock, say 6 o'clock, or 3 or 9 o'clock? 12, 3, 9, 6. And you'll probably see them mainly in this, maybe not 6 o'clock, but maybe like that 4 or 5 o'clock hour, swinging over to that maybe 7 or 8 o'clock hour. And the reason being is because if you go to this picture here, you'll see that this soap is irritating the epithelium and it breaks it down. And one of the clinical pearls I like to teach when I teach cornea is that what is the flow of fluid through the cornea? Is it front to back or back to front? And the answer that I like for people to realize, it's really front to back if there's no epithelium on that cornea. So for example, I have someone that comes in with a corneal abrasion. I put some sodium fluorescein in the eye, use a sodium fluorescein strip. I see Dr. Salkas calling me, rarely calls me during the clinic. It must be something important. Let me answer this. I step out of the room, I talk to Joe, come back 5 or 10 minutes later, look at that patient that had the abrasion. You see how that sodium fluorescein starts to be pulled into the stroma. And that's because of all those endothelial cells. When you have epithelium on there, if that patient didn't have an abrasion and I came back 10 minutes later after talking to Joe, you wouldn't see any sodium fluorescein in the stroma. So that epithelium is where I'm going, is when that gets broken down and that opens up and can suck things in, soap can get in there, other byproducts, other contaminants, pollution can get into that cornea. And then that's why you end up with that reaction. And we'll kind of focus that if we have some time when we get to the antivirals and how that's important in herpetic disease. So that's why you usually see these marginal ulcers right about where the soap is, irritating that epithelium because it breaks down the epithelium, and then you get those marginal ulcers. So that's the whole cascade. So where do steroids fit in? They inhibit right here, the phospholipase A2. It inhibits right here in this cascade. So that's why when you stop or use steroids, you're really not treating this whole cascade. And that's why I like to put this cascade out here. Wouldn't it be really, really cool if we had something that would inhibit lipase? And we all saw that in that opening question when I said, when we use doxycycline or minocycline for dry eye disease, ocular surface disease, and or meibomian gland dysfunction, what property? And 90%, 96 people said anti-inflammatory, inhibiting bacterial lipase. There it is right there. There's your bacterial lipase. This is the cascade, a simplified cascade of things that happen, but you're inhibiting, you're reversing that meibomian gland dysfunction. You're stopping that soap from being performed, and you're inhibiting the arachidonic cycle and the prostaglandin mediators. So steroids do work, but they don't treat at such a high level. And that's why minocycline and doxycycline become the drug of choice for this condition. I kept antibiotics small here because we really use it for its anti-inflammatory component and anti-collagenase part of this when you're treating meibomian gland dysfunction. The nice thing with this medication, there's no renal adjustment, and you're really using it as a steroid. So if you want to, for a couple weeks, use 100 milligrams once or twice a day. If they're really inspissated, pulse them. But the key is getting them down to about 40 milligrams or 25 milligrams on more of a steady dose, getting the anti-inflammatory, inhibiting those bacterial lipases, and getting that patient kind of a reversal of that. So that's why whenever I tell patients that they're going to be using doxycycline or minocycline, they might know it as an antibiotic, and they might know that they should only be taking an antibiotic for 7 to 10 days. I tell them we're not really using it for that. Dermatologists use it all the time to treat acne and other skin conditions. we're doing the same thing by treating their skin condition, which is an oil gland, meibomian gland, oil gland issue. And you could do things as, if the gland is inspissated, you hit them a little bit higher. As they become turbid, you bring them down. And then you might need a maintenance dose of, say, 20 or 25 milligrams. You can order a capsule or a tablet of 50 and just get a pill cutter, or have them use a butter knife, for lack of a better term, and just have them cut that pill and just get 25 milligrams after you get them. And there's the customized treatment. And there are other things out there like Oracea, and they're still really expensive. So my go-to is just get 50 milligram tablets and have them cut them in half, or get a pill cutter, online or at the drugstore, wherever they can find one, and cut that pill in half. There is some in the azithromycin, orally and topically. And this one actually came out of Florida before Florida had their orals. They used a lot of azocyte. A lot of that came out like, hey, you can use azocyte. And it was more driven by the drug companies than it was the Florida docs, and saying, hey, you can't do doxy, but so you can do azocyte. And again, the macrolides do have bacterial lipase activity. It's just not as high as doxycycline. So if you have someone that's allergic to minocycline or doxycycline, you can certainly move to the macrolides. They're probably going to be on it longer. You might have to use a little higher dose because it doesn't have the efficacy that doxy or minocycline does. So it's still the drug of choice, minocycline and doxycycline. But if there are issues, yes, the macrolides do have a little bit of, or they do have the bacterial lipase activity, just not the efficacy.
Hey, Greg, a question came in, mono or hyclate?
Yeah, I got it coming up right here. So that's usually about the timing when that happens. So just give me 1 second and I'll get there. So successfully treated. I think we hit this all pretty hard. I think everyone knows kind of how to treat that. There's been enough over the years here that, warm compresses, lid scrubs, get them on some fatty acids, EPA, DHA. I still like using minocycline and doxycycline. I will put them on steroids as long as they go on minocycline and doxy to kind of quiet the eye down and inflammation, get them feeling better, get that burning result. And then you can go into, all the specialized heating and expressing of the lipids, whatever you're finding out there. But I still like to use in my office, some course of mino or doxy. So that's a great, almost a perfect question. Thanks, Robert out there for that question. I get that all the time. I used to use, Tracy as this. The answer is it does not matter. That's the short answer. And the reason, and I'm going to change that in a second, just because they don't always come in tablet or capsule, but there are shortages out there from time to time. So you'll order, doxycycline, and they don't have the monohydrate. All they have is the hyclate, or they don't have the hyclate. It's up in price. All they have is monohydrate. In treating the condition, it doesn't matter. And that's why I have these vodka drinks right here. All these drinks have vodka in them. It's really the vodka that everyone wants. It doesn't really matter how you deliver it, right? It could be with orange juice. It could be with tonic water. It could be with gin, or it could be with orange juice or cranberry, or however you're taking your vodka. It's the vodka, right? It doesn't really have to do with the delivery system. And that's what monohydrate and the hyclate mean. It's just the way it's being delivered. One doesn't have a higher efficacy or lower efficacy than one or the other. The only thing I try to do when I start getting a little later in the condition, if I'm using 50 milligrams, I'd like for them to have tablets. That's the clinical pearl, because then you could do the tablets and have them cut them in half and maybe take 25 in the morning and 25 in the evening, as we're trying to get the patient to the lowest dose possible. So that's the hyclate versus monohydrate. It doesn't matter for efficacy. It's usually one is back ordered or not. So the side effects of doxycycline or minocycline, or the adverse drug reactions, as we like to say, if we were pharmacists and or in the pharmacology world, is that these things can create photosensitivity. And that's what this little cute little cartoon here is that I think we're all aware that doxycycline can enhance photosensitivity. So be careful if you burn in the sun to make sure you use a little extra sunscreen if you're taking it. You want to avoid in children and in pregnancy. It's nice. Category D, doxycycline. So A, B, C, D, we definitely want to avoid in someone that's pregnant. It can interfere with how penicillin kills. So if you're using it in a sense on a patient and they come in with a sty and you say, oh, I remember Greg said about Augmentin, it works great. You might not get the effect that you're looking for because it can interfere with the penicillins. It can enhance Coumadin and digoxin. And let me go with how this story goes. You have a patient coming in on Coumadin, warfarin, let's even say digoxin, that's usually a cardiologist. And you remember, oh, Greg said that the patient can have enhanced. And we're going to be putting this patient on for 3 to 6 months. So I usually call the cardiologist or the PCP up and I say, hey, look, I have a patient yours. They're on, warfarin. They got some really bad meibomian gland dysfunction. I'm going to be putting them on Doxy. Oh, don't worry about it. That's usually like for 7 to 10 days. It's not going to interfere. Oh, that's the reason why I'm calling, is because I'm going to be using this more as a steroid. It's anti-inflammatory effects like a dermatologist. Long story short, the primary care doc will get their pro times checked and the cardiologist will get their dig levels checked. It's not a reason to avoid. If you want to treat the patient, it's a reason to pick up and make a phone call and be a part of the team, be a teammate or be a team member in this patient's care, and get this patient, let them know. And then there's times when they say, well, let's not go there. I've been having trouble with their digoxin, and maybe they'll steer clear and you can try something else in your treatment. Joe, I think I might have messed this up. Is it idiopathic? It's not idiopathic intracranial hypertension. Or is it secondary pseudotumor? You're the one that taught me this. So let me go through and explain to the audience, and then maybe you can clarify this for them.
Okay.
We used to always say idiopathic intracranial hypertension is what it could cause. And Joe's like, Greg, when the person has a swollen nerve head or pseudotumor cerebri, and it can also be enhanced if the patient's on Accutane here, just not Accutane alone, just by taking minocycline, a patient can get a secondary pseudotumor or an intracranial. And Joe would say, why, is being the neuro guy, why do you call it idiopathic? I'd say, well, that's what I was taught. And he'd say, well, what's it from? Doxycycline. Well, then it's not idiopathic. So Joe, can you clarify that for us?
Yeah, those are the terms that we use. We think that idiopathic intracranial hypertension is the most correct term to use, but it really isn't. The most correct term to use is actually pseudotumor. Pseudotumor means increased intracranial pressure in the absence of tumor. But there are things that can cause it. And things can cause those minocycline, tetracyclines, hypervitaminosis A, oral contraceptives, venous sinus thrombosis. There's no tumor, but there's increased intracranial pressure, so that is pseudotumor, but specifically it's secondary pseudotumor. Now, if you don't have any of those causes or factors, or any cause or factor in there, and it's typically a younger female who maybe has gained weight or is a bit overweight, well, then we call that idiopathic intracranial hypertension, or we call that also primary pseudotumor. So that's really the status of pseudotumor in IIH. IIH, everybody thinks is the most, I guess, a politically correct term to use, but it really isn't. Pseudotumor is really the best term.
So in this case, a secondary pseudotumor.
Indeed.
Perfect. Thank you. Hyperpigmentation can be an issue. I'm going to show you some examples here. And then when a lot of patients or a lot of docs will ask, well, what about the antacids, or I've heard something about seizure medications, and I have them listed down here. It's not really contraindicated, but taking antacids, drinking milk, which has calcium, taking supplements high in calcium, or these different types of chemicals here can just inhibit how the doxycycline works. It just lowers the efficacy. So let's do polling question number 5 here. So I'm just curious, it's not anything. Have you ever seen this swollen nerve head that Dr. Salka described, this secondary pseudotumor in your practice from minocycline? Have you seen this? Have you not seen it? Maybe you saw a swollen nerve and you didn't realize that it was from. Just kind of curious out there to the audience listening. Have you seen a secondary pseudotumor, swollen nerve head, bilateral from doxycycline or minocycline?
And Greg, the hyperpigmentation is melasma. That was a comment or a question in the chat.
What was the question? I'm sorry, Joe.
What do you call the hyperpigmentation again? Melasma?
Melasma?
Mm-hmm. That's just a question from one of the people in the
It must have been to you. It might have been private to you. I just call it hyperpigmentation.
Okay.
All right. So we'll end the poll here because I think a majority of patients or majority of the attendees, the docs here tonight, have not seen it. 81% were about 13, and maybe 6% here are not sure. And the reason why I bring this up is because I practice in an office that has 5 optometrists in it. We do have a surgeon that's his private entity that he does come to our office once or twice a month to see our patients that need surgical. He's glaucoma, cataract, a doc, and cornea certified. So glaucoma, cornea, and cataract, both fellowships in glaucoma and cornea. So he comes into the practice, but he's not associated. So I'm just trying to set it up. We have 5 ODs, probably about equivalent of about 3.5 because I travel so much, and we have a couple part-time in a sense, a couple days off. So say 3.5. Usually in our office, we see this once a quarter. I just kind of want to show you that we're seeing this bilateral disc edema that comes in. And the question, Joe, that I'm going to throw out to you and have you wean in because you're the neuro guy here, is that we have this bilateral swollen nerve head. The question I usually get is the patients on minocycline or doxycycline, how do we work this patient up? Can we just assume with this bilateral swollen nerve heads, they're taking minocycline, doxycycline? Can we just assume that's what it is, stop it, and do no workup?
No, we should never do that. We just because they're on a minocycline or an oral contraceptive or is using vitamin A, that's not protective from a meningitis or a hydrocephalus or a malignant lesion. So this is something that must be done. You've got a potential cause in there, but looking at this, first thing that I think that you need to do in the office is check blood pressure, because it can be malignant, not intracranial, but malignant hypertension. Then probably if you can probably do a visual field, probably very quickly, OCT and photographs. But this person ultimately needs to go to the emergency room. And you need to tell the emergency room physician what is going on and what they need to look for. And don't just mention the minocycline, but they need neuroimaging, they need an MRI, they need an MRV, possibly an LP, and a consult with neurology. Because if you just send them to the ER, I can guarantee you what they're going to do is a CT of the head, a CT of the brain, because they're looking for a brain bleed, and that's because that's what they do. Now, you've got a potential cause, but you have to rule out the other causes first.
So here's another twist to that question that usually I get, and I'll let you answer it. And they usually say, okay, Greg, it's 5 o'clock on a Friday. It's always that 5 o'clock. It's 5 o'clock on a Friday. It's an 18-year-old child or young adult, and they're taking it for their acne. And this is most likely the cause. Are you still sending them to the ER?
Yep.
Yep. The answer is yes, right?
Yep. It's not, we don't know. It is a potential cause. But I can also tell you, in an 18-year-old person, 2 things happen to 18-year-olds: stupid things or really bad things. And this could be a really bad thing. Now, hopefully it is the minocycline, but 5 o'clock on a Friday, where's the best place to be? Where where everybody knows your name, not Cheers Bar, but open 24 hours, the ER. But help the doctors out. Tell them what you're thinking. Tell them what's going on.
So here's a patient that came in and they have the swollen nerves, and we were assuming, with the family that this was most likely from the doxy or minocycline, but we had to do the workup because it could be and most likely, or however you're feeling, but there still could be other bad things going on. So it ultimately came back that there was nothing else going on. The minocycline was stopped. And you can see that I just kept the timelines in here, and it's just an old case, but we see one of these about 1 a quarter in our practice, a bilateral swollen nerve head. Turns out most of the time it's from doxycycline or minocycline if they're on it. And you can see here time 0 being October 19th, 12 days later, you can see the edema going down, and 25 days later and 48 days, it's pretty much all gone back to normal. And if you remember what it looked like 48 days earlier, there was swollen nerve heads. That was pretty pronounced. So the patient had the bilateral swollen nerve head workup, as Dr. Salka discussed, but then it was minocycline and doxycycline, whichever one they were on, discontinued, is how this patient was treated. And again, just to kind of show you here that we do see these, here's another one that popped in. And usually when it happens, I go to ODs on Facebook and usually try to remind everyone out there, because there's a big population of optometrists that belong to that remember this can occur from this medication. Make sure that you do work them up. And you can see here over time, the edema does go down. And there it is again. Again, lots of edema here early, going down and going down even more as the medication. But again, the patient was worked up appropriately. That's out there. Here's a patient that comes into the practice and I say, hey, Mary, how you doing? And Mary goes, well, doc, everything's going well. Eyes are going well, but look what happened to my legs here. And no one can really figure out what's going on. And is it related to my cancer that I had treated, a year and a half ago? And, things are turning black and I've had some biopsy. And I just went like this. And Mary said, hey, doc, why did you do this? And I said, well, I did this because I did that to you. And she goes, what? And I said, yeah. I said, I did that to you. I said, remember when I told you that doxycycline can create that hypersensitivity, it can affect other medications like Coumadin and digoxin, and it's all those things that I was just telling you about on that adverse drug reaction. And I said, remember when I told you that it can create pigmentation of your skin? I said, this is what I'm talking about. She goes, really? Treating my eyes, putting it in my mouth, and this is what happened? So the answer is yes. And we were able to stop it. And you can see here that 6 months later, she did fade. I'll kind of give you a reminder what she looked like 6 months ago. So she did fade over time. And she even faded a little bit more in a year. And to kind of show you, this is what she looked like a year before. Sometimes it can be permanent. You could see there, she does have some residual. Another point that I like to point out, when patients come in with these medications, we do, as optometrists, take a drug list, and we do see people that are on it. So I like to look at the nerve. And I also like to ask them, look, are you having any other kind of pigmentations? And I've had patients come in and maybe I'm following for something and, in the office, and they'll come in, they'll say, hey, doc, remember that pigment? Is this these purple fingers what you're talking about? Or this little kind of pigmentation around my mouth? And that's yes. And if I'm not the prescribing doc, obviously I get the prescribing doc on the phone and let them decide what they want to do. But I've also found these pigmentations just by asking the questions when they come in. So just be aware that that's a side effect and that can occur. With that being said, there's some new medications that are out there, and I'll just hit them real quick just so you can see them here. Here's a fluoroquinolone that's been recently approved. There was hardly any new antibiotics. And then in 2017 and 18, kind of hit us. And what was really funny was the tetracycline group in 2018. There was a new tetracycline basically approved by mouth and IV. And another one in 2018, another tetracycline, and it said it could be taken without food, but that it does cause nausea. So all the tetracyclines and doxycycline should be taken with food. And another one, IV only, came out. So we had this dry run they're still very expensive. We're probably still going to be using minocycline and doxycycline as the go-to, but I just wanted to point out that there were some new tetracyclines and a new fluoroquinolone on the market.
Greg, before you move on to our next topic on antivirals, there are a couple of antibiotic questions I think we should try to cover. And one, do you ever prescribe diflucan or any sort of anti-yeast along with an oral antibiotic to prevent a yeast infection in women?
I have not. I have, recommended it. I always remind ladies, females, that yeast infection can occur. Usually when that happens and I remind them, they're like, oh yeah, I get that. I'm going to go take my, the medication. It's more, do I prescribe it? No. Do I remind it? Yes.
Hey, Greg, how long, and is there a cumulative dosage of doxy or any of the tetracycline drugs that increases the risk of pseudotumor?
Well, obviously, the longer the answers, they're going to be the chance of the pseudotumor. In my cases, they've at least been on it a year, but it's probably going to be closer to probably 18 months to 2 years. As the neuro guy, do you have anything out there in your brain swimming around of what the timeline of that is?
No, but it's usually with chronic usage.
Yeah,
it's not an acute hypersensitivity reaction.
Well, we just had someone scream from my family room here who is an optometrist. Can you repeat that? Because I didn't hear what you said.
My patient was only on it 6 months.
So my wife is an optometrist. She's kind of hearing in the background this whole webinar, and she said she had a patient that was only on for 6 months. So, so I would say again, chronic is the key.
And 6 months is a fairly long period of time.
It is. Yep. And everyone's going to react. So that's the fun part of pharmacology, right? Not everyone reacts the same way. So
I think we're caught up. We're good.
You caught up? Good.
Yeah.
Let's do a little quick crash course here. I think we have about
10, 20, about 25 minutes.
Okay, about 25 minutes. That's enough to get through the oral herpetic. I kind of have a herpetic eye disease that can be an hour to an hour and a half, but we'll just kind of focus on the orals. I think when we talk about orals and herpetic eye disease, I think we all kind of focus on Valtrex and acyclovir and Famvir. And that's where we're going to focus tonight. But I also like to remind people when it comes to orals in herpetic eye disease that you could see things like Neurat and Lyrica used and along with doxycycline out there for that post-herpetic neuralgia. L-lysine, it's more of an amino acid that could be used to help maybe decrease those effects. There's been some literature out there that shows that L-lysine is an amino acid. It's important for the immune system. We do not, our body does not make that endogenously. We have to get it exogenously, and by taking that can help out. Tagamet, it's out there with the different viruses that gets talked about from time to time. And back to post-herpetic neuralgia with the tricyclic antidepressants. So when it comes to orals in herpetic eye care, treating the infection is Valtrex, acyclovir, and Famvir, but there are some other oral medications that are out there, but we're just going to focus tonight on the anti-infective part of it. So some fun facts about herpes that's out there. They are the leading cause, one of the leading causes of human viral disease. It's only secondary to influenza and cold viruses. Now, that might be a little bit different than the last year when we talked about the coronavirus. Get ourselves outside the pandemic. Herpes viruses are a leading cause of human viruses, only second behind the influenza and cold viruses. I had a person come up to me, a doc one time, say, hey, my dog has herpes. Can that affect me? Great question. Let me do some digging on that. And I'll email you or give you a call back or something. So I did some digging, and doing my digging, I found out that there was roughly, and it depends on what literature piece you read, but about 130 herpes viruses that have been identified. But of those 130, 8 infect humans. It's 9 if you count the herpes human virus number 6 and divide it into 6A and 6B. So you could say 8 or 9, but when it comes to affecting the eye, there's only 5 that affect the eye or directly, and that would be herpes simplex 1 and 2, the zoster virus, Epstein-Barr, and the cytomegalovirus. And this is a pretty cool fact here, is that 25% of the population is seropositive for herpes simplex by age 4. So if you have a 4-year-old at home, or if we had 4 4-year-olds and we tested them all, 1 out of 4 would already be seropositive. Test for the antibodies, right? We're so aware now with the coronavirus, seropositive in a sense for the antibodies. But by nearly age 60, whether you're in the medical field or not, 100% are seropositive for the herpes simplex. So I would say everyone in here, if you're seeing patient care, no matter where you are in the recent grad to, getting later into your career, that you'll probably test positive for the herpes simplex antibodies, just because it's such a common viral disease. This slide here is just a reminder is that we know them as herpes simplex 1, 2, zoster, Epstein-Barr, cytomegalovirus. But you can see here that the human herpes virus, not the dog virus, but the human herpes virus comes in 1, 2, 3, 4, 5, all the way down through 8. If you count 6, A and B, then there's 9 of them. And then when you jump over here, it's just a reminder that these 5 here, simplex 1, 2, zoster, Epstein-Barr, and cytomegalovirus, are the ones that affect the eye. So when it comes to where they hang out in latency is kind of why you'll see the different effects that you do in the eye. So if you look at the column here, whatever the 6 columns here, the 5th one over, if you look at the latency, if you look to see where simplex 1, 2, and the zoster virus hang out, they're neuronal, right? We are aware that they hang out in neurons, and when they affect the eye, it's the trigeminal nerve, and it's the ophthalmic division, not the maxillary or the mandibular, but it's the ophthalmic division that this virus starts to come down or erupt. Now in zoster, it can be the maxillary or the ophthalmic, but for simplex, it's the ophthalmic division. And that's why you get that dendritic appearance. But in the Epstein-Barr virus or the cytomegalovirus, you usually kind of see more of a vitritis type of thing. And that's because it's the B lymphocyte is its host cell where it likes to kind of hang out and lay dormant until it, in a sense, becomes activated. And you could see the cytomegalovirus, maybe more of a vitritis in an immunocompromised patient because it's the monocells, the lymphocytes. That's where the latency of that virus hangs out. And that's why you get those different patterns. With regarding herpes simplex, it is the leading cause. Look at this statement. I think it's pretty powerful. It's the leading cause of cornea blindness in the United States. It doesn't say secondary countries. It doesn't say third world. It says it's the leading cause of corneal blindness. So when we talk about cornea vision loss, someone going from 2020 to 2025, 2020 to 2030, cornea vision loss, cornea blindness, cornea transplants needing done, it's the herpes simplex virus that's out there. And it's the nomenclature that I just want to put this up here to remind you is that you have the infectious epithelial keratitis, then you have the stromal keratitis, which is inflammatory, which we'll talk about in a second, endotheliolitis, and then the neurotrophic keratopathy. The varicella virus is the zoster virus. You can see that it takes on it's a more robust virus. It creates a little higher risk of maybe some ocular complications. And this here is one of my funnest patients that I love looking at this because this is when you want to catch it. This patient came in and she said, it feels like there's something crawling on me. I'm having this pain. And when you look at her, if I would just would have put her under the microscope, I probably would have missed what was going on. So when these cases come in, I've learned to become a little bit more, I guess, osteopathic, push the microscope out of the way, feel around, take a look. And I saw this little kind of scarring up here. But what I love about it is this picture right here. If you guys look at this, doesn't this almost look like a dendrite that we would see on the cornea? See how it's coming out of that neuronal pattern? It's following, that trigeminal nerve. This one's a little bit more advanced. You can see it's starting to kind of get a little scarring already, but this one's busting out. This is when we want to, you can see what's happening. Getting little blisters throughout the skin here, kind of following the neuronal pattern. See this swelling. This is zoster at its earliest phase. So this is when we really want to catch it and get them on Valtrex, 1,000 milligrams 3 times a day. So my pearl is kind of look around. So when you see them like this, they're already kind of end stage. You can put them on it maybe to decrease their viral load, maybe help them out, but you're probably not going to get the effect that you're looking for. So polling question number 6 is, have you ever had this happen to you where a primary care physician sends you a herpes zoster patient? Patient's already on Valtrex and prednisone. So, they were maybe at the primary care physician that day. Maybe yesterday they put them on there, yeah, you got zoster. Like, what the heck you here for? You're like, why are you sending this patient to me? Did you ever have that happen? So looks like everyone's rolling in here nicely with their questions.
They are.
No other questions rolled in, Joe, as they're answering?
Well, there is one. What about azithromycin for blepharitis treatment in comparison to doxycycline?
Yeah, we chatted on that a little bit earlier. Remember, we talked about how doxycycline and minocycline are the treatment of choice for meibomian gland dysfunction or eyelid disease because of the higher effect for the bacterial lipase. The macrolides, which that's what azithromycin is, you could use it. It doesn't have the efficacy. I would have to look up the dose. I know it comes in 125. I'd probably do 125 or the lowest dose possible. I don't do azithromycin. I haven't in probably 4 years used azithromycin. Have I done it in the past? Yes. I would probably go to PubMed and find out what our colleagues have used in the past to use azithromycin for the treatment of meibomian gland dysfunction. Again, it does inhibit the bacterial lipase, but doxycycline and minocycline have a higher efficacy.
Very good. Well,
All
here
right.
are our results.
All right. So yeah, it's happened to just about a majority of the docs out here, and some say no, and some said never. So this is why I brought that polling question up, because I had PCPs do this to me all the time. I'm like, what the heck? You have this patient comes in, they have a classic zoster. They saw the primary care doc. They put them on, 1,000 milligrams of Valtrex, maybe even some oral steroids because maybe the association with a Bell's palsy, and well, you treated everything. What are you doing? Just testing me? Like, what's going on here? What am I going to change? The answer why that happens is because when the primary care docs go to school and they learn, or the physician assistants go to school, they have learned that zoster can create a lot of ocular complications. It can create episcleritis, scleritis, keratitis, uveitis, iris atrophy, glaucoma, vitritis, retinitis, choroiditis, optic neuritis, and cranial nerve palsies. It can create vision loss. It can create scarring. It can create a lot of bad things. So even though they've been started, what they want is they want you to be the teammate. They want you to do a dilated fundus exam and report back to them and follow them for any ocular complications until this patient is out of the woods. So don't feel that they're testing you in any way. What they want to do is they're extending out the olive branch saying, hey, you are a part of this team. Can you at least give me an ocular Can you give me an ocular consult on this and report back and monitor this patient for any types of anywhere from the front of the eye, episcleritis, to keratitis, to then the inside of the eye, vitritis or retinitis, and then into neurological conditions like optic neuritis or cranial nerve palsies.
And I think it's really important, Greg, to underscore that, because primary care physician, I equate this to a corneal abrasion. Somebody goes to an urgent care center with a corneal abrasion. They get looked at with a Burton lamp. They get prescribed an antibiotic. They don't get an infection. They come into our office, and how do they feel? They feel terrible because they didn't get a cycloplegic. They didn't get a steroid. They didn't get a bandaged contact lens. The person with zoster may need a pressure lowering drug. They may need a topical steroid. These are all things that we can do that they know about, but they don't. It's not within their scope.
And we're starting to see that. I get that question a lot, and that's why I put that out there. So that was a great analogy, Joe. Thanks for that, kind of clarifying that or taking it to a different level. So thank you. The medications here, the acyclovir, famvir, and Valtrex. What I want to press upon you here is they're all cleared through the kidneys. Kidneys, kidneys, kidneys. And I'm going to say it one more time, kidney, kidney, kidney. And the reason why I'm going to say that is because we're going to potentially put these patients on a chronic dose, as maybe the herpetic eye disease study had taught us. And if you're going to do that, just make sure you work with that primary care physician, and they're not going to know, or they might need to be reminded, hey, I'm going to put this patient on, 400 milligrams twice a day of acyclovir, because that's what the herpetic eye disease study kind of taught us to help us decrease that reoccurrence. Or I can do 500 milligrams once a day. If you're going to move into that arena, just call the primary care doc and just say, hey, look, do you want to get some kidney function tests first? They might already have kidney function tests. They might tell you to go ahead and start it, and they'll get it, and then they'll monitor it. So be a part of that team whenever you're going to go chronic with these patients. All three of these medications, acyclovir, famvir, and Valtrex, all cleared through the kidneys. Make sure you're getting kidney function tests done. So if you're going to use acyclovir, you're typically going to use 800 milligrams 5 times a day for the treatment of simplex or zoster. Now, whenever you're going with zoster, it's the strongest bug out there versus simplex. Simplex is wimpy. You probably were taught in school, oh, if it's zoster, 800 milligrams 5 times a day. If it's simplex, you can get away with 400. I can tell you right now, these medications are super, super safe, and they're really cool the way they work. They go into every cell, but every cell that has the herpes simplex virus actually has an enzyme to turn on. It actually cleaves off a part of the molecule, turns on the molecule to kill the simplex. So if it goes into a cell that doesn't have it, there's no enzyme. The half-life, the metabolism of the cell, it goes away. If it goes into a cell that has the simplex or the zoster, the bug itself produces an enzyme that turns on the drug to then kill the bug. It's really, really cool, really, really safe. I give them at high dosages because I'm just trying to reduce viral load in this patient's body. And you're going to see this all along. Remember to check for kidney functions. It's category B. So if the patient is pregnant, it's a safe medication. Now, I always talk about off-label here because if you go to the PDR, you're not going to find any ocular indications for Valtrex and famvir because it's only approved for genital herpes. But you can use it for ocular conditions. It's the standard of care. You're allowed to go off label. We do it all the time. When we use a topical fluoroquinolone to treat a corneal ulcer, it's only approved for bacterial conjunctivitis. So you could use Valtrex and famvir. It's kind of like, one of those commercials, 3 out of 4, people prefer it. 3 out of 4 corneal specialists do it. So you could do famvir or you can use Valtrex. Now, famvir is just kind of lost out there. I think Valtrex and acyclovir, but it is a good antiviral. If you're going to use it, you can use it 500 milligrams 3 times a day out there. That's typically zoster or simplex. If you're going to go for recurrent from the herpetic eye disease study, you could drop it to 125 twice a day or 250 twice a day. It's category B. Again, they're all category B, all good to be used in someone that's pregnant, and they're all cleared through the kidneys. You just got to pick where you're more familiar, acyclovir, famvir, or if you're going to go to the prodrug of acyclovir, valacyclovir, and it's going to be 1,000 milligrams 3 times a day. Again, if you want to go 500 milligrams 3 times a day for simplex and so on and so forth, go right ahead. I'm going to tell you these medications are super, super safe. I just do 1,000 milligrams highest dose 3 times a day for a week and just kind of reduce the viral load in the body. Again, you'll see it clear through the kidneys. So make sure that their kidneys are okay if you're going to do it for a week. If you're going to go chronic, 500 milligrams once a day for that herpetic eye disease study you want to do, reduce that recurrence of that corneal ulcer, that dendrite. Make sure you get kidney function tests. Patients pregnant, it's very safe because it's category B. So the question here is, when it comes to these medications, beside dosage frequencies, 800 milligrams 5 times a day, 1,000 milligrams 3 times a day, Simplex, Zoster, if you go down that rabbit hole. Are there differences? And this is from the herpetic eye disease study. You could just see right here, it says the herpetic eye disease study. What was the main reason for discontinuation of the medication during the herpetic eye disease study? And the number one reason was gastrointestinal side effects. And in the study, if you remember, they used acyclovir, and gastrointestinal side effects was the number one reason why these patients stopped. So with that being said, polling question number 7 is, which oral antiviral is lactose free? Is it acyclovir, Famvir, Valtrex? They all have, or you don't know. Is it acyclovir, Famvir, Valtrex? They all have it. Or that's why we're here tonight. We just don't know. I think we got a pretty good representation.
Yes, we do.
So as Dr. Saka is sharing that, I see 3% have said acyclovir, 12% Famvir, 15% Valtrex. They all have it. And the majority is we don't know. And that's great because I'm glad I put this pearl in here then. So with that being said, if you look at the package inserts, and if we go back and we look why the number one reason why people dropped out of or had issues, or the side effect that was in the herpetic eye disease study was gastrointestinal, I'm going to circle them here for you so you can see it. You can see Zovirax here, or the acyclovir, has lactose. You can see Famvir has lactose. So we're going to the inactive ingredients, but you can see here Valtrex is lactose free, and all of the generics are lactose free. So again, I try to bring home pearls to help everyone when they're in clinic, hopefully tomorrow. You'll be able to put this to use if you have a patient that comes in with antibiotic issues or with herpes simplex. I tend to go to Valtrex because this is the main reason. One, it's a prodrug, or main reasons are it's a prodrug and it's lactose free. It's really easy to remember, 1,000 milligrams 3 times a day, herpes simplex, herpes zoster, and I like going for it because it's lactose free, and we do have a lot of lactose intolerance. Now, are there any side effects from these medications, meaning CNS? And these agitations or hallucinations, it could be confusion. But I did have a patient recently come in that had bilateral cornea transplants. They were transferred out of the Pittsburgh area to about 2 hours closer to me. They're living with their daughter now. And this patient still had pretty good vision after having bilateral transplants, meaning 20/50-ish. And she was having these Charles Bonnet-like hallucinations where, hey, I'm seeing, my boyfriend, I'm seeing my granddaughter, this type and that. And the patient was taking 1,000 milligrams of like acyclovir, and she was like 98 years old and like 100 pounds. So knowing this, we slowly brought her down, and her Charles Bonnet and hallucinations went away. So I called the corneal specialist, and we talked about it. He goes, yeah, I just never know. I didn't know why I never brought her down. That's true. She probably doesn't need to be on that high of a dose. And we saw that go away. So knowing this fact, we could. Now, my next step would have been to maybe switch her to Famvir, because when you look at all three of the drugs or all three of these medications, Famvir has the least amount of agitation, hallucination, and confusion. I didn't have to do that with my patient that came in, but that would have been the next step if the reducing of the Valtrex did not clear that up. So just a reminder that Famvir has the least amount of the CNS adverse effects, but remember that all of these have CNS side effects. So what happens whenever you have this happen? You have a patient that comes in with a dendrite, and you want to prescribe Zirgan or Viroptic, and you write off to the pharmacist, and the pharmacist calls you up and says, hey, I won't be able to get this for the next 24 or 48 hours. What are your thoughts on that? Is that okay? Well, what can you do? So in this case here, since this one is centrally located, I would put this patient on orals only, or since it's centrally located, put them on put an amniotic membrane on them. So are there studies out there? Is there a difference? And the answer is it's okay. There are plenty of studies out there that are showing that statistically significant, you can go oral versus topical on these patients. So oral acyclovir alone appears to be as effective as topical in the treatment of simplex epithelial keratitis. Now, I can tell you that what I do in my practice is when a patient comes in and they have central location, I always try to get some type of topical on them just because of the location. If it's out in the periphery, I will definitely go with just an oral. If I can't get the Zirgan in this case, I will probably put an amniotic membrane on there to help control the scarring until maybe the Zirgan comes, or until I see that the Valtrex is clearing. Now, another clinical pearl is I have a local pharmacy that always keeps Zirgan in stock for me for these central locations. So that's something that you can do, is work with your pharmacist. But just trying to give you lots of data out there that they are showing no statistically significance between time to resolution by using topical or orals. So the key here is if you ever try to do Zirgan and they don't have it, definitely go with orals. I usually do both because I'm just trying to reduce viral load for the patient.
Greg, just a real quick aside, talking about reducing viral load. It is very old fashioned or an older treatment. And with the advent of antivirals, it has become somewhat antiquated. But before we had antivirals, about 75% of these would be treatable by debridement. Now, when I say debridement, I mean a gentle rub. I don't mean removing the epithelium like you're doing epiLASIK or PRK. Nice roll with anesthetic, roll, a gentle swab, a little swipe, and you're going to remove a lot of virus there, and that will help with the subsequent treatment, in my opinion.
And I'm going to take that to the next step of when I went way back when we were talking about the bacterial lipase and that scheme that we had. And I explained to the audience here tonight and the colleagues that when that soap sits down there at 6, on that lower lid margin and irritates that epithelium, and the epithelium opens up, now it's that vacuum cleaner because of the endothelial cells to pull things in. And what happens if you think about when a simplex comes into the cornea, it comes in through that corneal nerve, which is the trigeminal nerve, and it starts to open up. And that's why when you stain it, you get that classic dendrite. Now think about what we just did, and it's genius what Joe was just talking about, because what we do is we use Zirgan and we use Valtrex to kill that bug. And when you kill that bug, you have an opening in the cornea. The vacuum cleaner's turned on. Where is that dead bug? Where is that dead protein going to get sucked into? The stroma. And that's why you end up with that margin, or you end up with that inflammatory reaction. And that's why we call the stromal reaction inflammatory. And that's why it needs a steroid. So yes, by doing that, that would be great to do to reduce the viral load and minimizing the amount of bug that's on that eye to create that corneal reaction. So with that being said, vaccines is not really part of the orals, but you usually get a question on it. There's 2 types of vaccines out there. There's Zostavax, and I think we've learned a lot about vaccines with the coronavirus. The Zostavax is less effective. So as a guy that's 50 now, when I go for my vaccine, I'm going to reach for Shingrix. Zostavax is that attenuated virus. It's weakened but it only has about a 50% effective dose. It's the Shingrix, which is a recombinant vaccine, which gets you up to that 90% plus efficacy. So we definitely moved in the right direction by going for Shingrix. So a lot of the questions are out there, especially when Tracy and I do this together. Which vaccine should we go with? If you're going to go for a zoster vaccine, where you're going to counsel your patients, counsel them to get the Shingrix. I'm not even sure if the Zostavax is even out there that much anymore, but I would go with the Shingrix with that question that's out there. So with that being said, I think that puts us right at like Delta landing on time here, Joe. Are there any questions out there that I need to address?
Yeah, there are a few things we can talk about. Do you ever recommend a patient take Lactate to help with side effects of an antiviral that has lactose in it?
I have not had patients use Lactate. I would probably just go to something that's like Valtrex, that's lactose free.
Do you ever consider? I mean, do you ask a patient if they're lactose intolerant?
I used to, because maybe if I wanted to use acyclovir, but now I've just gone into using Valtrex most of the time. I really can't remember the last time I wrote for Famvir or acyclovir. Valtrex is generic. Maybe if it was on back order and I couldn't get it, I would probably go to acyclovir, and I would definitely ask if they were lactose intolerant. And if they were, just kind of warn them, say, hey, look, we got to take this. You got zoster going on. You got this. You have to deal with some GI issues. And then at that point, you can maybe go with Lactate or something along that line.
Yeah, there's a fair amount of lactose intolerance out there. You know, me personally, I think I'm just lactose impatient. Now, can we use both topical and oral for a dendrite?
Yes, I do it all the time. If someone comes in, especially a central dendrite, I will put them on Zirgan 5 times a day. And then I'll put them on 1,000 milligrams of acyclovir. They're usually cold sore sufferers, so they don't mind having their viral load reduced. And then I'll add the steroid when I start seeing reversal.
If you're doing that, do you do half the dose of zoster for orals if you use them both?
I do not. Again, these medications are so safe, and I'm reducing viral load. I try to keep things simple. There's nothing wrong with doing it either way, in my opinion. Obviously, I do 1,000 milligrams and 3 times a day, whether it's Simplex or zoster. And obviously, I'm talking about, and that's what I do. So I'm going to say, hey, that's the right way. I'm not going to say that's the only way or right way. But if you felt comfortable and you wanted to do 500 3 times a day, if Simplex, you can. But zoster, always keep it higher.
When would you need to keep a patient on a maintenance dosage of an antiviral?
Yeah, maintenance dose is, from the herpetic eye disease study, that's where it came out, is when that patient starts having that recurrent dendrite. I would start thinking about it on the second dendrite within the same year. That's usually not what happens, though. You have a patient that comes in, let's say on January 1st, they have a dendrite. You clear it up. You warn them that it could come back. There's about a 25% chance it can come back in the first year. And if they come back, and then jumps up to almost 50% chance. At that second visit, you could say to them, look, there's a 50% chance that this can come back now. First time they have, it's 25. Second time it comes back, it's like 45 or somewhere in that range. But it's like a 50% chance that it can come back. We have that discussion. They usually say, hey, doc, if it happens a third time, then we'll go on it. So when they start having multiple recurrences in a short period of time or within a year, I think you should have that discussion, because there is a study out there called the herpetic eye disease study number 2 that said if you put a patient on 400 milligrams twice a day, you can reduce the reoccurrence by 41%. So if you're going to do, if you're going to, play doc in a sense, make sure you know that study, because if they start losing vision loss, someone might say, why didn't you ever offer that to the patient? So the second time within a year would be the short answer.
And in response to a couple of requests, I did just repost the handout.
Great.
Now, if somebody has previously had shingles, how soon after it can they get the shingles?
We've had that question a lot. I've heard Tracy say about 2 weeks is whenever they can have it.
And is it a live vaccine also?
It is not. It's not an attenuated virus.
And that's it. That looks like all the questions.
All right. So I want to thank everyone for attending tonight and attending oral antibiotics and antivirals. I really hope that you were able to, again, find, I don't want to say pharmacology is simplistic, but hopefully that if a patient comes in and they have something that needs an oral antibiotic, that you can work through a matrix a little bit easier on picking the right antibiotic. And the same thing when it comes to antivirals. If you have someone that comes in and has a herpetic infection, that it does give you a little bit of sense of comfort and ease in prescribing the medication. So thank you for attending tonight. And Joe, thanks for being a great host and moderator.